I'm Dr. Shereen Abdelghaffar, Professor of Pediatric Endocrinology, Cairo University. I'm honored to be with you in this prestigious conference held by the AESD, and I'm pleased to talk to you about the type 1 diabetics in adolescence, to fast or not to fast, and the risk assessment between the old and the new guidelines. This is a common scenario in our clinics before Ramadan when a diabetic adolescent comes to our clinic and says, "Doctor, I want to fast Ramadan." And this is the normal reaction of most doctors. "No, you must not fast." The doctor tries to do the risk assessment and communicates this to the parents and the child. However, for religious, cultural, and social reasons, many of them don't listen to us and insist to fast. So this is my agenda. I will touch briefly on: is fasting Ramadan different for type 1 diabetic children from the healthy? Are there any risks? What does the research tell us? How strong is the evidence? The risk stratification, the precautions and adjustments between the old and the new DAR guidelines. And then I will touch briefly on the results of an Egyptian study that was held in Cairo University in that relevance. Let me present to you Layla, one of the patients who is coming to us before Ramadan, aged 14 years, 7 years duration, and she wants to fast. She's doing self-blood glucose monitoring twice per day. She's doing the carb counting. Hemoglobin A1C is 7%. The AC ratio is 20. Her average blood glucose is okay. And she's on basal bolus insulin therapy, 1.2 unit per kg per day. What would be our response? Tell her must not fast, or should not fast, or may fast? And would that be different in the case of Ahmed, who is 15 years old, coming with type 1 diabetes diagnosed 8 years ago? He wants to fast, but then when we took a medical history, we found that he had DKA 2 months ago, frequent severe hypoglycemia and hypoglycemia unawareness. His hemoglobin A1C is 8.5% and the AC ratio is 40. His fasting plasma glucose and postprandial are high with high variability, reaching sometimes to 300. He's on basal bolus insulin therapy. What would be our response? We would tell him must not fast or should not fast or may fast. And would that be different in the case of Ali, who is 13 years old? He has type 2 diabetes diagnosed 3 years ago, coming and wanting also to fast. He's practicing sport. He's doing proper weight management. He's doing self-blood glucose monitoring every other day. His hemoglobin A1C is 7.2%. The ACR is 10. The fasting and the postprandial blood glucose are okay. He is on metformin 3 times daily and Glargine at bedtime. Would we advise him that he must not fast or should not fast or may fast? Before answering that, let us see how in type 1 diabetes fasting is really different. The challenge number 1 is that in type 1 diabetes, these patients are insulin dependent, and because of fasting, they will receive inadequate insulin doses and only twice at iftar and suhoor instead of the 4 times. And because they are usually afraid to experience hypoglycemia, they usually decrease the dose. What is the net result? We found most of these patients coming to us with hyperglycemia, ketosis, and DKA. And this has been proved by studies before, as you see here, Abdelghaffar et al. 2016, who found that DKA was significantly higher in Ramadan and the following month than the preceding 6 months. What about the challenge number 2? The change in the sleep patterns during Ramadan will lead to insulin resistance. The challenge number 3 is that the change in the sleep pattern and the change in the cortisol circadian rhythm will lead to defective hormonal counter-regulation against hypoglycemia, and this will lead to decreased glucagon secretion, epinephrine secretion, especially if these patients have autonomic neuropathy and have recurrent hypos. So they will experience hypoglycemia. And this has been proved by many studies before, documenting that severe hypoglycemia is 4.7 folds in patients with type 1 diabetes during fasting. And what about the most risky challenge, number 4, is the dehydration and the thrombosis due to the limitation of the food and the fluid intake during fasting, because hyperglycemia will produce osmotic diuresis. This will lead to hypercoagulable state, and studies have documented increased incidence of retinal vein thrombosis, increased blood viscosity thrombosis, and stroke. So the DAR guidelines, the previous one, have documented the risks and have provided us with the risk assessment, the very high risk who must not fast, the high risk who should not fast, and the moderate low risk who may fast. And concerning our adolescents, the poorly controlled type 1 diabetes, as you see, have always been considered must not fast, having very high risk, while the well-controlled type 1 diabetes have always been considered a high risk who should not fast, and only those with well-controlled type 2 diabetes treated with metformin or basal insulin are considered to be moderate or low risk and may fast, but never in type 1 diabetes. So if you go back to Layla, we should tell her she's high risk and should not fast. What about Ahmed? He is very high risk and must not fast. Ali, who is type 2 diabetes, yes, well controlled, he may fast, but I am talking today about the type 1 diabetes patients. And this has been approved by the Mufti of Egypt and all the fatwa that type 1 diabetic patients should not be by any means encouraged to fast. Let us look to the new 2021 DAR guidelines, and let me show you some examples. For example, if we have a poorly controlled type 1 adolescent, as you see here in the red boxes, hemoglobin A1C above 9%, he takes a score of 2. Because he's type 1 diabetes, he takes a score of 1. And because he is on basal bolus insulin therapy, he takes a score of 2.5. This means a total of 5.5. So a poorly controlled type 1 adolescent can be considered through this scoring system to have a moderate risk and will be encouraged to fast, although he is poorly controlled. Let us take another example of a type 1 diabetic adolescent who experiences hypoglycemia 1 to 6 times per week. So he takes a score of 2. And because he experiences hypoglycemia, his hemoglobin A1C is less than 7.5%. It was erroneously interpreted as good metabolic control, but it was low because of the hypoglycemia. So he takes here a score of 0, type 1 diabetes score of 1, basal bolus score of 2.5. Again, a type 1 adolescent with hypoglycemia 1 to 6 times per week will be considered by the new guidelines as having a moderate risk and will be encouraged to fast. So the suggestion is always that we should consider type 1 diabetic patients as high or very high risk. However, if the child insists to fast during Ramadan and it is his own decision or the parent's decision, he will be advised to do insulin adjustments regarding the insulin basal analog reduction by 15 to 30%, the rapid acting analog taking a iftar the same dose, omitting the lunch dose, and reducing the suhoor dose by 25 to 50%, and should receive structured education and check his blood glucose regularly at least 6 times per day, adjusting the nutrition, keeping the well hydration, mild to moderate exercise, and should be advised to break the fast if the blood glucose is less than 70, more than 300, or if there are symptoms of hypoglycemia, hyperglycemia, dehydration, or acute illness. Let me touch briefly on a study that was done in Cairo University hospitals looking into the risks and metabolic consequences of Ramadan fasting on children and adolescents with type 1 diabetes mellitus. This was an observational study. Retrospective, clinical and laboratory data were recruited from the files and the hospital records before Ramadan. And then from Ramadan onwards, the study continued to be prospective with follow-up of the clinical and laboratory data of the patients even after Ramadan in Shawwal month. The number of the patients included in the study was 109, aged 8 to 16 years, and children with an age of 18 years insisted to fast during this study. The fasting group were 76, while the non-fasting who insisted to fast were 33. And these are the graphs which show that the mean frequency of occurrence of hyperglycemia was significantly higher before, during, and after Ramadan. And actually, hyperglycemia was the most common complication experienced in 66 patients in the fasting group and in 24 patients in the non-fasting group. The other graph here showing the mean frequency of occurrence of hypoglycemia before, during, and after Ramadan, which is also significantly higher in the fasting group than the non-fasting group. Hypoglycemia occurred in 60 patients in the fasting compared to 24 in the non-fasting. And what about the DKA? It was significantly higher in those fasting, but did not occur in those non-fasting. So DKA developed in 15 patients during Ramadan and 17 patients during Shawwal in the fasting group, while none of the non-fasting group developed DKA, or none of them were dehydrated during Ramadan or Shawwal. These are the mean hemoglobin A1C before and after Ramadan, which show rise in the hemoglobin A1C in the fasting, then in the non-fasting group, and also the mean fructosamine after Ramadan was higher in the fasting than in the non-fasting group. So the conclusion and recommendations here would be that type 1 diabetic children and adolescents should be considered high risk or very high risk for fasting. But those who insist to fast during Ramadan should seek medical advice concerning the risks involved and should be warned against fasting. Patients who insist on fasting should undergo pre-Ramadan assessment and receive appropriate comprehensive education at least 1 month before Ramadan from all the members of the diabetes team, adhere strictly to instructions given by all the members of the diabetes team, and be aware about probable complications associated with fasting and appropriate means to deal with them. They should receive proper dietary advice, individualized meal plans to ensure adequate balanced diet during Ramadan, to delay the suhoor meal as late as possible before the start of the daily fast, and avoid skipping this meal in order to prevent prolongation of the fasting hours, increase the number of the blood glucose measurements, which could be an early index of the risks related to fasting, use proper carbohydrate counting for meals to match the insulin dose. At last, individualized Ramadan-specific treatment regimens should be provided for each patient and should be sensitive to regional and cultural factors. The insulin type, dosage, and timing may need to be modified per individual clinical needs to minimize the possible risks during Ramadan fasting. And lastly, risk assessment of type 1 diabetic children should use higher scores to ensure that they are always risky to fast. The evidence-based approach should be always applied, which denotes an individualization of the approach for every patient. Thank you very much, and I'm pleased to have any questions.